All right, hello. I'm Avery Trucott, and today I'm going to be discussing federal policy responses to the synthetic opioid crisis, specifically focusing on the adoption and implementation of these policies. So, I just wanted to start off with a brief overview of my presentation. I'm going to start by discussing the adoption stage of my policies. First, the political landscape, then comparing different policy alternatives, and identifying the key decision makers and stakeholders. Then I'll go to the implementation stage, starting with federal coordination and then going to local partnerships. And then finally, the importance of stakeholders and collaboration in this stage. Okay, so the main focus of this presentation is how federal and state actors move policies from planning to action. There's three areas. First, the political feasibility of different alternatives. So, how realistic and practical each option is within our current political environment. Second, the importance of understanding who makes the decisions and how those decisions impact policy movement. And then finally, coordination across different agencies and levels of government is essential for policy execution. All right, so first up is the political context of adoption. Policy adoption is shaped by both political feasibility and institutional fit. When it comes to expanding medication assisted treatment or MAT, it's one of the most straightforward policies to adopt. This is because it has bipartisan support and it aligns with existing frameworks set by the Department of Health and Human Services and the Substance Abuse and Mental Health Services Administration. Since these agencies already fund and manage MAT programs, adoption would mostly mean modifying current funding structures rather than creating something new. Now we can compare policy alternatives. So I made this little chart to compare different policy alternatives based on their feasibility and existing support. So first up, we have MAT expansion. I gave this one 4 stars for political feasibility. This is because this option already has broad support and it fits current funding structures, so it stands as a very strong option. Harm reduction, including syringe service programs or supervised consumption sites, these get 1 star since they face a lot greater resistance. Even though research shows that they reduce overdose deaths and disease transmission, many opponents believe that they encourage drug use instead. Some states have even passed laws criminalizing fentanyl test strips, which limits adoption significantly. Naloxone distribution is an exception. It gets 4 stars because it's proven to reverse overdoses and carries almost no political risk. It's widely supported, and it can be adopted across party lines. And diversion programs like law enforcement assisted diversion or LEAD, these ones fall somewhere in the middle with 3 stars. They're promising. Research shows they can reduce repeat offenses and can be implemented on the local level. Incrementalism is the most realistic adoption path. Expanding MAT and naloxone first would offer the best plan for building support before going on to more controversial harm reduction policies. Next are the decision makers and stakeholders in the adoption phase. So, in Congress, the Senate Committee on Health, Education, Labor, and Pensions, and the House Committee on Energy and Commerce would oversee legislation related to treatment and prevention. Executive agencies like the HHS, SAMHSA, and the Office of National Drug Control Policy would lead the rollout once a policy is approved. And advocacy groups like the National Harm Reduction Coalition and the American Medical Association provide guidance and research, while law enforcement organizations can weigh in on diversion and enforcement policies. The hard part here is finding an agreement between enforcement oriented stakeholders and those advocating for public health solutions. That's usually what will determine whether or not a policy moves forward. Now we can move on to the implementation phase. So once a policy is adopted, this becomes the central challenge. The crisis needs very strong coordination between public health agencies, justice system, as well as local partners. On the public health side, SAMHSA takes the lead on treatment and prevention through its state opioid response grants. The fiscal year 2025 federal budget allocates $21.8 billion for treatment and $459 million for harm reduction. Much of this is distributed through HHS and SAMHSA. The DEA receives about $3.3 billion to address fentanyl trafficking and criminal networks, but enforcement alone hasn't lowered overdose deaths, which is why the current approach now blends enforcement with public health strategies. So most harm reduction and diversion programs are implemented locally through state health departments and community groups. SAMHSA identifies these local groups as key partners in distributing naloxone and running syringe service programs. For diversion programs like LEAD, city and county agencies take the lead and work closely with police, prosecutors, and service providers. Research has found that these programs are most successful when agencies share information and maintain strong communication. To scale up nationally, the DOJ could support by funding local pilot programs, offering standardized training, and collecting consistent outcome data. Moving on to stakeholders in the implementation phase. So, at the federal level, agencies like HHS, SAMHSA, the ONDCP, the DEA, and the DOJ provide funding, oversight, and enforcement. State and local governments can tailor treatment and prevention programs to their populations using federal funds. And community and advocacy organizations like the National Harm Reduction Coalition and Shatterproof push for stigma reduction and connecting people to care. And then there's a little bit of opposition to supervised sites from some law enforcement and political groups, which does slow down progress. But I went ahead and added a Venn diagram just showing that when these three sectors overlap, successful implementation can occur. So, key takeaways: adoption depends on political feasibility and expanding what's already working, like MAT and naloxone, through incrementalism. Implementation depends on cooperation among federal, state, and community systems to make those policies function in the real world. And then agencies like HHS, SAMHSA, and the DOJ provide the infrastructure, while local organizations bring those policies to life in their communities. Ultimately, reducing overdose deaths requires policies that aren't just well designed, but also politically feasible, properly funded, and coordinated across every level of government. And these are my references. And thank you.